note, let's go ahead and get started.
Thank you, Len. So hi, everyone. I'm Jocelyn Cooper. I'm one of the second-year allergy fellows, and today I'll be talking to you about complement and complement disorders. This was a topic I did not know a lot about before doing this talk, so I've learned a lot. I hope this is either a good review for all of you or that you'll learn something new. So I have no disclosures. These are my objectives. So we're going to go through each pathway and understand where things can go wrong and what that looks like clinically, and then how to perform diagnostic testing if you're suspecting a complement disorder and how you might manage a patient with the complement disorder. So beginning with nomenclature, so when we're talking about the classical pathway, each of the proteins will have an uppercase C and then a number. And just to note that when we're talking about C1, 2, 3, 4, and 5, those were named in order of discovery and not necessarily in order in which they appear in the cascade, which makes it even more confusing. And then you've got the alternative pathway. You'll see factor with an uppercase letter, and then all of the other protein fragments are lowercase letters in the identifier. So what is complement and what does it do? Complement, we now know, is comprised of 50 complement proteins either in the cascade or that regulate the cascade. And it actually makes up about 5% of our total serum proteins, so they're quite important. Most of them are produced by the liver, but there are some exceptions. So C1q in particular, we'll talk about later, but that's produced by the myeloid cells, and then factor D is produced by adipocytes. And the primary function of complement is immune surveillance. It has a lot of other functions we've learned about since, but opsonization is one of the main things. Is it works with immunoglobulins to opsonize microbes or cells that need to undergo destruction. Something I learned is that the word for opsonization comes from a Greek word that means delicacy. So if a cell is opsonized, it makes it look more tasty to the neutrophil, and then the neutrophil will want to consume it. Other things it does is induces an inflammatory response and ultimately lysis of bacteria or other cells. So complement was originally named because it was discovered as a portion of the serum, a heat label portion of the serum that complemented the heat stable antibodies and killing of microbes. And then it's also been found to be not only an innate, but an adaptive immune component. So it also can activate B cells and prime T cells. And then in addition to protecting you against infections, it also has a role in kind of cleaning up apoptotic debris and ensuring some sort of homeostasis in the endothelial cells. And this becomes important when we talk about autoimmunity and the complement disorders. So here are all of the pathways that we remember so well. There's the classical, the mannose-binding lectin, and the alternative pathways, and these converge into the terminal pathway or the membrane attack complex. And so we'll go through each one individually. The classical pathway was the first pathway discovered, hence the name, and it is activated by immune complexes. So IgG, IgM, it's also activated by different apoptotic contents. The main feature of it is this giant C1 complex, which is comprised of C1q, which is the main large molecule in the middle, and then it has two C1rs and two C1s's. And this is what interacts with your IgG or IgM. And then this leads to the cleaving of C4, C4b from that leads to the making of the C3 convertase, and each of the pathways ultimately leads to making of a C3 convertase that can cleave C3 into further products. And then in the alternative pathway, so this one is interesting in that it's just spontaneously activated all the time by polysaccharides, endotoxins, things in the environment and in your immune system. So it is always on at low levels. And this is known as tickover. So tickover hydrolysis of C3 is always occurring. It's always making C3b. And depending on if that lands on a bacterial cell or a host cell, the alternative pathway will turn on or off. So it's highly regulated. And then further down the pathway, you've got C3b interacting with factor B here. I'm pointing out these different things because we'll talk about them later in terms of disorders. So this complex is then cleaved by factor D to form BB. And then you've got C3b-BB, it's a mouthful. This creates C3 convertase in this pathway. And then we will talk about piperidin. So this molecule stabilizes this complex. And then it keeps on going to make more and more C3b. All right, and then the lectin pathway. So this is activated by oligosaccharides, primarily mannose. So that's why you have this mannose binding lectin. And this MBL protein looks a lot like the C1q right next to it. You can see they're both collectins. They're both in the same family. So you have the mannose binding lectin, and then you have these things called MASPs, MASP1 and MASP2. And these are activated by the MBL protein and things called ficolins. And then MASP1 and MASP2 will cleave your C4. And then you'll end up with actually the same complex that occurs in the classical pathway, the same C3 convertase. And then that leads you to the terminal pathway. So you've got membrane complex. So you end up with C3b through any of those three pathways we just spoke about. And then this will help form the C5 convertase. And then when you get C5b, that binds to C6, 7, and 8, and that initially forms a hole in the lipid membrane of a cell. And then when it binds to C9, that forms the full pore that ends up in lysis. So another interesting thing about complement is that it is directly involved in the inflammatory response. So as you produce C3a, C4a, C5a, in the cascade, these are factors that increase blood flow and increase vascular permeability. It allows more immunoglobulins to flood in and inflammatory cells to kill pathogens. C5a in particular is really strong at attracting neutrophils. And something interesting is that in sepsis, they've found that C5a can be overactive, and too much C5a can cause neutrophil aggregation. And then this results in actually an overall immune suppressed state. Okay, so this is the regulation of complement. We'll talk about a few of these different proteins that regulate things and how they might result in different complement disorders that we now know. So C1 inhibitor, we are all familiar with HAE. And then there's factor I, factor H. These are really important in regulating the alternative pathway. We'll talk about decay accelerating factor, CD55, as well as membrane cofactor protein, CD46. And then CD59 is important for inhibiting the membrane attack complex. This is a visual of just some of the functions of these regulatory proteins. So on the top left, you have factor H, and this inhibits the C3 convertase formation depending on what surface it's on. So if it's on an activating surface, meaning it's on a pathogen, it'll allow alternative pathway to continue. If it's on a host cell, it will halt that process and prevent it from being attacked. Then you have these other ones that we just spoke about. So they have all these different functions just to keep your host cells safe, essentially. So this is just a snapshot I made from the IUIS 2022, which describes the known genetic inborn errors of immunity, kind of putting them together by phenotype. So on the top row, you have the early complement deficiencies, which we'll talk about. All of them present with can present with some form of lupus or at risk of developing a lupus-like condition. And then they all have issues with encapsulated organisms, infections. And then second row, there's the C5 through C9, the terminal pathway. If you remember, that is always associated with Neisterial infections. And then further down, there's issues with regulator proteins causes overactivity of the complement pathway, and that can lead to atypical HUS, hemolytic anemia, and other issues. And then there's kind of the more unusual ones. There's C1 inhibitor hereditary angioedema, not unusual in terms of what we see, but just slightly different phenotypes. And this is the same.
Go back a second.
Sure.
Well, I don't know what CHAPLE disease. What is that?
I'll talk about it later.
Okay,
It's very rare.
good.
So this is the same information just presented in the actual IUIS paper. It groups it together by phenotype, but then it also kind of from left to right by their susceptibility to infection. So on the left, you've got disseminated neisseria infections with your terminal complement deficiencies, and then some of the alternative complement deficiencies have risks of pyogenic infections. And then you've got your lupus-like syndromes, your atypical HUS, and then the ones on the right that are kind of in their own category. So HAE, hemolytic anemia, and then this Chapel disease. So in terms of epidemiology, overall, these are very rare diseases. They are even rare amongst the inborn errors of immunity. So as many as 10% of all IEIs and an estimated prevalence of 0.03%. We'll talk about some exceptions because there are some populations that have complement deficiencies that have quite a mild phenotype or are asymptomatic. So it's very possible that there's a lot of people walking around with complement deficiencies that are just not, very clinically prominent. So but it's also good to know that if you're dealing with a patient with really severe lupus or early onset lupus, you would want to check for complement deficiency because it's prevalent in that particular population. And then we'll also talk about atypical HUS. A lot of those patients have complement deficiencies. And then any adult that's had bacterial meningitis or recurrent sepsis is someone who you might want to screen for a complement deficiency. So this is a little bit of a busy chart, but I like it because it splits up the different pathways, the different kind of genetic issues that have been found in the pathways, what they might present with, and then the epidemiology. And I'm just going to point out that some of these have maybe 2 or 3 cases that have ever been found, and then others are a lot more prevalent. So like MBL is presented in 5% of Caucasians. The inheritance pattern overwhelmingly is autosomal recessive, but we'll talk about some of the exceptions later. All right, so starting with the classic pathway. So here again, we have the C1q, C1r, C1s complex that we went over, and then the kind of the different molecules that are, or sorry, the different proteins that are involved in this pathway. So C1 deficiencies, C1q is most well known for causing lupus. So there's been about 70 cases of C1q deficiency, and most all of them develop lupus early in life. Although it's overall a rare cause of lupus, it's the strongest genetic risk factor. And patients who have lupus with C1q will have more cutaneous findings and more CNS findings, and then they are also more resistant to steroid treatment. These patients also have a susceptibility to infections like anyone with the early complement deficiencies. And then C1R and S can be deficient. There's very few cases of this. They'll have lupus and glomerulonephritis. And then if you have a reduction of C1R, you will functionally have a reduction of C1S because they're both really needed to make the complex work and vice versa. So C4 deficiency is interesting because so a lot of the population actually has a partial C4 deficiency. So C4 is encoded by 2 genes, C4A, C4B. There's a big variation in the population in terms of how many alleles you have. So most people have 4, but you can have anywhere from 1 to 8. And then a complete C4 deficiency is where you have no C4A and no C4B, and that's very rare, but these patients present with lupus. And then if you have a partial C4 deficiency, the number of your null alleles actually correlates with your risk of lupus. So the fewer alleles you have that are functioning, the more likely you are to get lupus. And then overall, C4 levels can be pretty difficult to interpret, which some of us may have experienced. But part of the reason is that a lot of people do have a partial deficiency. And then also the people where you're looking for the C4, maybe they presented with an issue like lupus or HAE or something like that. And maybe they have an active comorbid autoimmune disease that's causing their C4 to be secondarily low. So it's a bit difficult to know. So for this reason, there's additional functional testing that you might pursue, and ultimately in this deficiency, you have to do genetic testing to look for the gene copy number to diagnose these patients. And as with all these diseases, infection is a major cause of morbidity and mortality. So C2 deficiency is interesting because it's very common, actually. It's present in 1 in 10,000 Caucasian people, and most people are asymptomatic. There is a predilection for people to get lupus, so about 50% women more than men may develop a lupus-like syndrome in early adulthood. And a feature of this type of lupus is that they'll have more anti-Ro antibody and less anti-DS DNA. And then something we'll talk about a little bit later is that these patients have been found to have an increased risk of atherosclerosis.
That's another question. If you're completely, maybe this answers it, if you're completely C2 deficient, you can still activate your terminal through the other pathways.
Yep. So this next slide I didn't go through in great detail, but there are some proposed mechanisms by which these patients are asymptomatic. So even if you have this homozygous C2 deficiency, people do pretty well. So just a reminder that C2 is this catalytic subunit in the C3 convertase of the classical and the lectin pathway. It's shared by both of them. But through some various studies, it's been shown that this can be overcome by adding high specific antibodies, and through C1q, through the classical pathway, and through MBL or factor B in the lectin pathway. And if you have a functioning alternative pathway, your complement finds a way around having less C2 and can kind of make it function in a normal way. So because of these redundancies in the complement system, patients with this, and also we'll talk later about MBL deficiency, can actually do clinically quite well, unless there's other things going on with them, or if there's succumb to an infection. So C3 deficiency is very, very rare and very, very severe. There's not been that many cases reported of this. There's an increased prevalence of it in a certain South African population. But these patients, because they don't have any C3, really none of the complement cascade can work. So they have really bad infections, abscesses, sepsis, meningitis, and then they also get pretty bad autoimmunity, more so this membranoproliferative GN, more than lupus. But then there's also been found people who have hypomorphic C3, and so they can be actually asymptomatic if they have enough of function of their C3. And then there's C3 gain of function. So naturally that leads to an overactivation of complement. And we'll talk more about some conditions that cause overactivation of complement when we talk about the regulation portion. But this will result in atypical HUS, vasculitis, and something called C3 glomerulonephritis, which is quite rare. So I want to pause here to talk about infectious disease in our complement disorders. So we always talk about the encapsulated organisms, the top most common being strep pneumo, H flu, and Neisseria meningitidis. I also mention these because you can vaccinate against them. But then there's also like Salmonella, Klebsiella, Pseudomonas, and other bacteria that people can be susceptible to. And ultimately, all of these bacteria have a capsule that helps protect them against complement. Strep pneumo and H flu cause your sinopulmonary infections, can cause meningitis and sepsis. And then your Neisseria meningitidis, which we think about with the terminal pathway specifically, that's your gram-negative diplococci, which you see off to the right. It's actually colonized in your upper respiratory tract, but then whether or not it can invade and cause other disease is dependent on host factors. So is your complement working essentially, and other things. But some of the virulence factors I found from Neisseria meningitidis, not only its capsule, but it has these different proteins that interact with complement. So factor H binding protein, and then there's this thing called LOS, and this helps the Neisseria mimic the host cell. So it just pretends to be a host cell, and then your complement doesn't attack it. So it's pretty clever. And then I wanted to talk also about lupus and complement. So why do all of these early complement disorders get lupus or are at risk? And it's hypothesized that the early complement cascade is needed to clear immune complexes and apoptotic debris. So if you're not clearing those, this may lead to autoimmunity and the production of autoantibodies. And as we talked about, there's varying degrees of lupus risk with these different complement disorders, C1q being kind of the highest risk. And then I was reading some papers about C1q, and they research kind of like what it has to do with lupus, but a third of lupus patients in general develop these C1q autoantibodies. But it's not really clear if the C1q antibodies are just a byproduct of activation of complement or if they actually cause disease. But it is associated with renal involvement in lupus. And then, as you know, if someone has active lupus, you get overactivation of the complement cascade, and if you check labs, you'll find low C1q, C4, C2, and C3. And then thirdly, I wanted to talk about atherosclerosis and complement, which is interesting. So there's the thought that complement may regulate LDL and vascular injury, and activate the alternative pathway and lead to plaque formation. And in atherosclerotic plaques, they've found complement products inside that may correlate to disease state. And then when they were studying this kind of larger cohort of C2 deficient patients in Sweden, it was found that patients with C2 deficiency had a fourfold increased risk of cardiovascular events than the general population there. So in that cohort, there were 40 patients, and they followed them over 25 years. And a lot of patients at a fourfold risk developed heart attacks, strokes. Some of them had multiple events, and this was thought to be, related to their C2 deficiency. But I think overall, when we think about autoimmune diseases and complement disorders, they're probably all somewhat at risk of atherosclerotic disease, because we know that in rheumatoid arthritis and lupus, that's a big cause of morbidity and mortality in that patient population. So complement likely has something to do with some of this inflammation that we see.
Well, that last point is important since C2 deficiency is common. Is
Yeah.
that just this one report, or is this more broadly true that C2 deficiency increases cardiovascular events?
I think this was the biggest like population-based cohort I saw, but then there's other studies just talking about the mechanism of atherosclerosis kind of from like cardiology journals, that complement may have to do with some of the inflammation that you see. Um, but I didn't see other really big studies about the cardiac risk factors.
Okay.
Yeah. So some take-home points. I know this is a long lecture with a lot of different parts, but I'll try to pause and kind of see what the takeaways are here. So I would say that in early complement defects, you should know that these are associated with lupus, and then all of them can have infections with encapsulated organisms. C2 deficiency is actually very common, and a lot of these patients are asymptomatic. And then when you're talking about complete C4 deficiency, it's a bit hard to pin down, but and it is very rare, and you can't just diagnose it with your screening tests that we'll talk about. It actually has to be diagnosed with genetics. Okay, so now talking about the alternative pathway, and then we'll go through alternative and lectin pathways. These disorders are a lot less common, but we'll go through them just to illustrate, where things can go wrong and what happens. So to remind ourselves, you've got your properdin there that stabilizes the C3b BB complex. You've got your factor B that binds to C3b, and then you've got factor D, which cleaves the complex below. So, Len, yes, we will talk about prepared and deficiency. So this is the important thing to know is that it's the only X-linked complement deficiency. And of course, it leads to an impaired activation of the alternative pathway. There's been 100 to 500 cases, and most of these patients have had at least one meningococcal infection. I will touch on these briefly because they're very rare, but factor B deficiency, there's been 2 cases reported. These patients had really bad pneumococcal and Neisseria infections. And then factor B gain of function would be associated with overactive complement, and that can lead to atypical HUS. And then factor D, this is the factor that cleaves factor B and C3b into BB in the alternative pathway. Also very few cases and leading to infections. So the lectin pathway, again, we have this mannose-binding lectin protein at the center. The phycolins are the, in addition to MBL, the things that get activated in this pathway, and then the MASP-P2 is a portion of this as well. So those are the ones that have been found to have disorders associated with them. So the mannose-binding lectin deficiency is also quite prevalent. So it's been found in 2 to 7% of the general population. And in a healthy adult, this doesn't mean a whole lot. There's no distinct phenotype. They're overall asymptomatic, lead normal lives. But through some studies of the flu and more recently COVID, patients who have infections with MBL deficiency do worse with these viral infections. And they also have overall an increased risk of invasive infection. And earlier we talked about the C2 bypass, and one of the bypass mechanisms for C2 is MBL. So if you've got low MBL and low C2, I imagine that you would be at increased risk of an invasive infection. And then these patients also can have autoimmunity. Phycolin 3 deficiency is very rare. You may have an impaired response to polysaccharide vaccines in this deficiency. And then MASP-P2 is also pretty prevalent in certain populations and can have a mild phenotype. And probably this is due to the redundancies in the complement system. And then terminal pathway, so C5 through C9 deficiencies, as we know, are all associated uniformly with Neisseria infection, so disseminated disease and meningitis. And I'll just point out a couple of kind of epidemiologic things about these. So C6 is more common in African American and South African populations, but it's not really seen elsewhere. C8, the thing to know about C8 is that it's comprised of alpha, beta, gamma chains. So the C8 beta is more common in Caucasians, and the C alpha gamma is more common in African Americans. C9 deficiency is actually pretty prevalent in Japan and Korea. 1 in 1,000 actually carry this homozygous nonsense mutation. And when you're testing for C9 deficiency, your CH50 will be diminished but not absent, so it can be a little bit difficult to diagnose. All right, so our take-home points about the rest of the pathways that we just went over. So the alternative and lectin pathway defects are a lot less common than the early and terminal complement pathways disorders. And the prevalence really depends on what population you're looking at. All of them have some increased risk of invasive bacterial infection. And then interestingly, MBL deficiency has been linked to severe illness in COVID-19. And then the board question is that prepared and deficiency is the only X-linked complement deficiency. So moving on to regulatory disorders. So on the left are some of the regulatory proteins that I mentioned earlier that may result in disease. And then on the right is just an image of, so now we're down to our terminal pathway, and that can either result in MAC assembly and killing of a pathogen, but then you also have to protect your host cells from your own complement. So a host cell will have all of these proteins and kind of receptors on its surface to help prevent complement from just destroying your own host cell. All right, so this is one we're familiar with. So C1 inhibitor deficiency, 1 in 10,000 to 1 in 50,000. This results in HAE. And these patients also have some autoimmune risk, including SLE. And then on the right, you can see there's all these different treatments that we have or are being developed for C1 inhibitor replacement or to inhibit other parts of the pathway, such as kallikrein and bradykinin. So I'm briefly going to mention HAE. I know it's not the focus of this talk, but it's an autosomal dominant complement disorder. SERPING1 encodes the C1 inhibitor, and different mutations in this have resulted in a familial angioedema. So it results in this unregulated activation of the classical pathway. It leads to excess bradykinin production and angioedema. Here you can see the pitting edema of a hand. It can also happen in the extremities, the face, abdominal pain. And there are different lab values that you check for. So the C1 inhibitor level and function, depending on what type you have, either will be low. You'll have a low baseline C4, which gets lower during an acute attack. And then there's also this type 3 that's a bit mysterious that has a normal C1 inhibitor and C4. All right.
When you're talking about that, I think it's important to point out that hereditary angioedema really has nothing directly to do with the complement system at all. That C1 inhibitor in this case is acting as in the kinin system, and it's bradykinin, obviously, that's causing the swelling. Calling this protein C1 inhibitor actually led to delay in understanding hereditary angioedema because people kept looking for complement fragments that were causing the angioedema.
Yeah, it's interesting how it's quite different. So maybe it should have been classified kind of in a different way.
Yeah, if it had been named bradykinin inhibiting protein or something much earlier, it led to really, I think, kind of decades in not understanding hereditary angioedema.
All right, so now I'm going to talk about factor I and factor H deficiencies. These are important regulating factors in the alternative pathway. And a deficiency in either factor I or factor H tends to look like a secondary C3 deficiency. So it can look pretty severe with these prominent bacterial infections, abscesses. They can also have renal disease due to this unchecked C3 convertase formation, because in the alternative pathway, you have tick over. So if you're not controlling that, then your complement is always going to be active. And then for factor H, similar presentation. It's interesting that 15 to 30% of patients with atypical HUS will have a defect in factor H. It can result also in age-related macular degeneration due to unchecked complement destruction. And then the reminder about factor H is that it really depends on what surface you're talking about. So if it's an activating surface, a pathogen, it should be killed by complement. And if it's a non-activating surface like a host cell, it should be left alone. But when you have a deficiency of factor H, your cells are not going to be protected. And there's, of course, other proteins involved, but this is why you get destruction of your cells. And then there's these factor H related protein deficiencies, just to note that there's this whole network of inhibitors and promoters of the alternative pathway that can go wrong. And then this is called the membrane cofactor protein. It's a cofactor for factor I. There's not that many cases of it, but you'll present with later onset AHUS or C3 glomerulonephritis. And then to pause and talk about atypical HUS. So atypical HUS is a TMA that results in hemolysis, AKI, and thrombocytopenia. It's resulted from alternative pathway destroying your endothelial cells. And it's called atypical because it's not the typical HUS where STEC or Shiga toxin producing E. coli diarrheal disease precedes it. It's not preceded by an infection. And like I mentioned earlier, a lot of these patients do have a genetic complement defect. And then this is called decay accelerating factor, CD55. It's one of the proteins that protects against complement-mediated destruction of your host cells. It's very rare, and the Chapel syndrome, so that stands for complement hyperactivation, angiopathic thrombosis, and protein losing enteropathy. So this is the syndrome that is associated with DAF deficiency. And then you've got CD59. This is another thing that's present on the surface of the cell that helps prevent complement from destroying your host cells. And deficiency in this is seen in paroxysmal nocturnal hemoglobinuria, and overall you'll get hemolytic anemia because your red cells are not protected from your complement. So PNH, this is a rare acquired disorder of adulthood that is a mutation in this PIGA gene, and that gene results in a deficiency of this GPI anchor on your hematopoietic cells. And the GPI anchor is important because it actually anchors down these complement proteins, the CD55 and the CD59. So without the anchor, you basically have a deficiency of these complement regulatory proteins, and the red cells are lysed by your own complement. So some take-home points here. Complement regulation is super important so that your host cells are not destroyed by your own complement. And disruption in that can result in AHUS, PNH, and then AMD, macular degeneration. And then briefly, we touched on HAE, which is a bit of a different beast. So getting into diagnostics, so the commercially available tests that we may be familiar with are CH50 and AH50, and this is essentially measuring if the alternative pathway or the classical pathway are intact by measuring the terminal pathway components. So if you have a patient who has recurrent bacterial infections, sepsis, meningitis, maybe they have early onset autoimmunity, lupus, or AHUS, these are all patients that you might consider screening for a complement disorder. So for the AH50, that measures the alternative pathway, and you're looking at the dilution at which 50% of hemolysis is measured in rabbit cells, and then CH50 is measured with sheep red cells. And then there's additionally non-commercially available testing, aside from C1 inhibitor, for the different complement components, their split products, the different regulator proteins that could be send out tests if you were not sure about your results with your screening hemolysis labs.
I've never understood why in the world anybody would use sheep red cells or rabbit or chicken red cells. Where in the world that came from?
I don't think I found an answer to that
Yeah,
either.
I don't think I've never had anybody tell me an answer for that. Just random.
I let me show you this image, and maybe it'll come to me, but as to why. But the CH50 on the left, so you've got these dilutions of patient serum, and then you add the antibody-coated sheep red blood cells, which will activate your complement in the classical pathway. And then you measure the basically like the hemoglobin or the hemolysis of your cells, and which dilution that occurred at 50%, hence the CH50. And then the AH50 uses this particular buffer that prevents I guess, the other pathways from activating, so the classical and the lectin pathway. So you're just measuring the alternative pathway. Len, I'll have to look that up later as to why rabbit RBCs are used, or sheep.
Yeah, I don't think you'll find an answer. I mean, I don't know why you wouldn't use human red cells, but
I think actually, oh, I remember now. I think rabbit cells have some sort of sialic acid, or don't quote me on that, but it's some sort of thing on the surface that more so activates the alternative pathway, so things that it likes to respond to. So I think maybe that has to do with it, like just the way that the cells are, that makes the test work a little bit better.
if you find an
Maybe
answer,
get
let
some
me know.
immunologists on this call that could tell me. So I wanted to go over common pitfalls of CH50 because we may have run into this in our own experience. So if you have a low CH50, the first thing you should wonder is if the specimen was appropriately handled, because there's a lot of different things that can go wrong. So the complement components are unstable. So if it's not run the same day, or it's not frozen to be assayed, then things might degrade, and then the sheep RBCs hemolyze pretty easily. And then the rabbit antibody affinity really varies from batch to batch, so you need to make sure you have an adequate control. And so ultimately, if you have a low test that's not 0, then you should repeat it, just for that fact alone. But when you're interpreting these tests, if you have a CH50 or an H50 of 0 or close to 0, that's when you should think more about if you have a complement deficiency on your hands. If you have a low CH50, and it's not quite 0, you should think about what else is going on. So does the patient have active lupus? Do they have GN or some other consumption process? Or are they, do they have liver disease? Are they not able to produce the proteins from the liver? Infancy is another case in which this is just an immaturity of the liver that can't produce enough complement. And then also to point out that there are certain complement deficiencies that the hemolytic assays may be normal or low. So you would have to do further testing of the complement components, especially in C9 deficiency and the lectin pathway, and for properdin as well. And I like this chart because it just kind of shows like what your differential should be. If you have low CH50 and a normal AH50, you should be looking at the early complement deficiencies. If you've got low AH50, normal CH50, you're looking at the alternative pathway. And then if both are low, this is because you probably have something wrong with your terminal pathway or C3. And then I think factor H and factor I, there's some variability in what the test can look like. And so to touch again on genetic inheritance, most of these genes are autosomal recessive, with some exceptions that are autosomal dominant, like C1 inhibitor deficiency and some of the gain of function mutations. And then properdin deficiency is X-linked. And so clinical management of these patients really surrounds protecting them from infections. And so vaccination with conjugated vaccines is recommended to make sure that they have an adequate immune response with high titers. So for strep pneumo, H flu, and Neisseria, meningitis, these all have conjugated vaccines available for them. And earlier we talked about C2 bypass and C2 deficient patients. And in those patients, one of the things that is helpful to prevent infections in them is high titers of specific antibodies. So having kind of overwhelming the immune system with higher titers may be helpful if you've got someone who has kind of one of these less symptomatic complement deficiencies. And then you could do prophylactic antibiotics in a patient-to-patient case basis, but it's not really supported by data. And there's not really any recommendation to replace immunoglobulin in these patients. And as we talked about, there's a lot of different comorbidities that can be associated with these conditions, such as lupus, other autoimmunity, renal disease. And something interesting to point out is that earlier we talked about complement proteins being mainly produced by the liver, but C1q is actually in the myeloid cells. So a bone marrow transplant could be considered in those patients. And this is just a slide to point out that complement is a hot topic of research right now. There are all of these different novel therapeutics in different fields like hematology, nephrology, neurology, rheumatology. There's a lot of interest in complement and the regulatory complement components in developing these different drugs. So eculizumab, the C5 monoclonal antibody, was developed initially for PNH, I believe. It has a lot of other approvals now. So it's an interesting area of research that we should be aware of. It's kind of, it's pretty interesting. So in summary, complement is very important for our innate and adaptive immunity, and it's highly regulated. Overall, these disorders are quite rare, even amongst our inborn errors of immunity, but it's possible that if you looked for more complement disorders, you could find them because there are certain ones that are prevalent in the general population. As we saw, there's a big variety of severity, different phenotypes, depending on where your complement is affected. And some of the patients who don't have any symptoms, we think is due to the redundancy of our complement system. We talked a lot about different comorbidities in these patients. We talked about how to diagnose with or how to screen with our hemolytic assays, but that not all complement disorders can be screened for in this way, and that genetic or functional testing may be necessary. And then when we're treating these patients, we want to just vaccinate them and treat their comorbid conditions, but there's not really any, silver bullet, just like a lot of our other inborn errors of immunity, just kind of protecting them from these risks. Now I'll pause for questions and I'll give you all the word of the day, which is disorders. Thank you for listening.
Thanks, Jocelyn. I'm not sure I have any more questions. My main comment would be whoever invented this system made it much too complex. When you make things this complex, you're almost certain going to have mistakes. But anybody else? On that last slide of monoclonal antibodies or therapeutics regarding this, the only one that I knew, go back to that slide. This one here. The first one, I know that's an existing product that was developed to treat PNH, paroxysmal nocturnal hemoglobinuria. Are the other products, all the other ones listed below, are those existing therapeutics?
These are existing, and then the list is actually a lot longer for the ones that are being investigated. These are the ones I found that have been approved.
So all these products exist and
They
have
exist.
a purpose?
Yes.
Interesting. What, especially, since the recent pandemic of COVID, was this product existing? Below, however you pronounce it?
Vilobelimab. It was approved under what is that called? Emergent. It had an emergent approval by the FDA in 2023. I never saw it used in residency because it just came out, but when I was talking earlier about C5a being overproduced in sepsis, and I guess maybe something like ARDS, I'm just speculating, but in this hyperinflammatory state, perhaps targeting that could reduce some of the issues with severe COVID-19. I think that was the idea behind it. I actually don't know how effective it is, but it was approved last year.
Interesting. A little bit of personal history. When I was at the NIH, I worked with the guy who discovered C5a as the main chemotactic factor from the complement system. And there was a strong dispute between that and another laboratory as to whether C3a or C5a were the main chemotactic factors. And it turned out the lab working that published a paper saying C3a was the main chemotactic factor had contamination with C5a. But if you look in the literature, for a long time, it mistakenly labeled C3a as a chemotactic factor, which it isn't really. C5a is the most potent one out of the complement system.
Yeah, it seems like we're always learning more about the complement system, and all of this started, I think, in 1890. It was discovered, and then I think 1950 was when maybe the alternative pathway was discovered. So a lot of this is pretty recent, I would say.
Yeah, while you were talking, I looked up. I always remember that the guy who discovered properatin committed suicide when he was declared wrong in his discovery that there was no such factor. His name was Pillamer. Just a tragic event in science. Other comments or questions?
Good morning, Len. This is Vinod here. Good morning, and good morning, Jocelyn. And that was a really good, review, and for a compliment, with when I was in fellowship too, it was pretty dry, kind of a very complicated, dry subject, but you made it really interesting, and you explained it really well. So good job on that.
Well, thank you.
as a community allergist, in terms of thinking about PNH or atypical HUS, how much should I or how much should a community allergist in terms of then start looking into, underlying other complement issue that may be more that may contribute them to risk of infection? It's not something that I see often, but on occasion we do see pediatric patients who say, "Oh, I've had HUS. How much do I actually then look into complement as a concern for deficiency and risk of infection?" Thanks so much for answering the question.
Oh yeah, I think if I understand the question, I think if we are an allergy clinic or even immunology clinic, they're coming to us most likely because of early onset autoimmunity or infections, recurrent infections. So if they've had recurrent infections or atypical HUS in itself, I would say if you have someone with atypical HUS, since 50% of them have a genetic complement disorder, you should probably look for it. But then there's the patients who have the regular type of HUS, and I don't think that one's associated with a genetic issue. And then, of course, these patients may not show up to us first. They may show up to someone else, like their nephrologist or rheumatologist. But I think it's just as we are like also immunologists, we should just be aware of all of the research, I guess, that's going on in the background of this complement system and the potential it has for therapeutics. But yeah, you may not see it in your everyday because it's even rare among the inborn errors of immunity.
Thank you for the explanation. But, if for somebody in an allergy clinic, I did do pediatrics many years ago, but if you ask me what's the difference between HUS and atypical, I don't think I would know. Is there a pearl or something you would say that as an allergist you'd say, hey, what is it that what comprises atypical HUS without actually having to know more about it?
Yes, that's a good question. The only thing I know about atypical HUS is that it doesn't present with the preceding diarrheal illness like the STEC. I did internal medicine, so I didn't really see a whole lot of HUS, but that's my understanding, is that there's no kind of infectious trigger. I'd have to look into, and I guess the mechanism is thought to be the overactivation of complement somehow.
Other
Thank you.
questions, comments?